I've added the stream. Oh, starting. Receiving your content. There you go. Stream health is yellow. Right.
Check for audio.
Cool. Except the URL is wrong, isn't it? But the URL is wrong, so no one's going to come to this one.
We've got 7 watching.
Oh yeah.
It's live.
Hello
It's
guys.
good.
Right, Baz. You're on.
It's ready.
Okay.
Here you go, mate. Hey guys. Thanks for joining us. I've got Mr. Bhaskar Thakur, who is one of the complex spine surgeons at the Royal London Hospital, and he's kindly taken some time out to join us and answer some questions in general about complex spine surgery, neurosurgery, life as a neurosurgeon. So we've got a few quick questions to start off with, and one of the first ones was from Instagram from Nicola Newell. We didn't realise we were live, so sorry, we had quite a few technical issues. Just going to go on Instagram, and so, or actually we'll start with a question from Danny, if we can, if I can even get through to these. So Bhaskar's just come from Bart's Oncology Clinic, has had a pretty long day already. So let's start with a question from Nicola. What triggered your special interest in treating complex spinal disorders?
Okay, well, I guess during neurosurgical residency you get exposed to a wide spectrum of things, from cranial neurosurgery to spinal. I think the spinal surgery is technically challenging, and there's an opportunity to do a lot for your patients. There's a lot of patients with pain, cancer, trauma, a lot of different indications for treatment, and I think you can do a lot for them in terms of their quality of life. So it's attractive for several reasons. Does that answer that question?
Yeah, I think that's a pretty good answer. So we've got actually 3 other questions from Nicola. Conflict of interest. She helps out with Brainbook. She's one of our members, but she wants to be a neurosurgeon. She's a medical student, so a lot of these questions are going to get things going. If you want to ask more questions from Mr. Thakur, you can pop them in the comments section, and we'll try our best to answer them. So, any particular surgery or moment throughout your career that you've been most proud of?
Well, I think life as a surgeon, there's moments that are proud of and moments that fill you with sort of grief as well throughout your training. There's lots of ups and downs, and I think these moments come and go as you increase your experience. When you're junior, even doing the simplest operation for the first time on your own can be very rewarding. So I think there's lots really. I think most recently, over the last few years, I think getting through my training and finishing my surgical exams was probably the happiest moment, to finally be done with exams, because it's a long haul.
And that's the fellowship of the Royal College of Surgeons.
Yeah, so in the UK we have a fellowship exam for the Royal College of Surgeons, which is a specific neurosurgery exam. So for the later years of training, that's a big hurdle and requires a lot of studying. So I think that was a particularly proud moment getting through that.
And how long did it take you to prepare yourself for the FRCS?
Yeah, so the book work really started probably around 4 to 6 months before the exam. And then there was a written part to start with, followed by a clinical part. So all in all, it was at least 9 months of studying, I'd say. So it really is a long haul.
It's a very long haul.
Whilst you're balancing your clinical work as well. So it's particularly hectic. You're doing busy on calls, long days in theatres.
Yeah.
And then having to go home and revise at the end of it, it's not easy for anyone.
It's not great for work-life balance.
Yeah.
Which actually leads us on to another question from one of our community on YouTube.
Yeah.
That is, who was this? This was Jamie Ong, who said, neurosurgical residency can easily consume a resident entirely in terms of time, physical, mental and emotional capacity. What are some challenges that you've faced particular to neurosurgery, and how did you learn to find a work-life balance?
I think that's difficult in any field, but neurosurgery is particularly demanding, I think, of a lot of medical specialities. In some ways, there's no substitute for spending time in hospital, in theatre, and that requires a lot of time and energy on the part of trainees. But it is important to find a balance. I think you can definitely spend too much time at work, and if you don't have anything to counteract that, whether it's hobbies or spending time with friends and family, just something that takes your mind off it, I think you will suffer, and your work will suffer, and your patients will suffer as a result. I've tried to keep a few hobbies going. It's not easy, but I still play the piano from time to time, so I find that helps me de-stress. A lot of people do sport. We have some very active people within the department, people running Ironmans and marathons and things. So
absolutely.
All sorts of things. I don't think it really matters what you do, as long as you have something to take your mind off work.
Fantastic. Thank you. And we've got an interesting question from Gideon. What is the difference between orthopedic and neurosurgical spine surgery? Do they perform different types of spinal operations?
Okay. So broadly speaking, there are some operations which any spinal surgeon can do. You can train in spinal surgery from the orthopedic side or from the neurosurgical side, and people can choose to go into spinal surgery. There are some efforts in this country to unite the two and have a joint spine training program, which is sort of slightly parallel to those, but that hasn't yet taken effect. In particular, orthopedic surgeons do more scoliosis and deformity correction.
Yeah.
That's not something neurosurgeons will generally do in their training, and we don't go on to do that. Whereas neurosurgeons will do intradural work, a lot more tumor work, vascular malformations of the spine. So really, those are the key difference. I think that there's a slight different skill set, particularly for the sort of intradural tumor work and vascular work. There's a lot of work under the microscope, which is something I think we do more of in neurosurgical training. So there is still some separation. All spinal surgeons will do a lot of the decompressions and fixations, and whether you train from neurosurgery or orthopedics, you can do that.
Yeah. Fine, fantastic, thank you. Right. What other questions? Let's go back through. What would you say, so this is Sharon Glenn, what would you say are the attributes of a good surgeon?
Okay, that's a
Deep,
tricky question.
deep
That was
question.
a very deep question.
Yeah.
So I think when we first think of what makes a good surgeon, immediately you start thinking of, okay, you've got to have good hands, you've got to have good hand-eye coordination and things like that. But actually, I think the actual technicalities of performing the surgery, once you've trained and once you're able to do an operation, becomes one of the less important things. There are definitely a lot of operations which are very technically demanding, and not everyone can do them. But actually, I think the technical side of it is often, less, well, not less important, but less demanding than a lot of the other things which we aren't always taught to do. Things like the interpersonal skills, how to run your service, how to teamwork well with your theatre staff, with your ward, how to have everything organised. I think running a surgical service involves all of those things. And actually, a lot of those things, just making sure your patients are looked after very well in the ward, does a lot more for your patient outcomes than simply just how good an operation you do.
Yeah.
So I think all of those personal attributes and really caring about your patients, spending time with them, team working, in particular for neurosurgery, on top of that, I'd put in sort of being calm under pressure. I think a lot of our decisions are made under pressure. There's a lot of stress going on. So again, these are more the sort of personality traits rather than just good hand-eye coordination and manual skills.
Absolutely. Thank you. Right. Azul Kalma. Have you ever made a mistake or failure during surgery? How do you deal with that and keep going with the work that you do?
Yeah.
Some really deep questions coming
These
through.
are very deep. Making mistakes is a part of life, unfortunately. We do all make mistakes, and it can be very difficult to deal with, especially those mistakes can have grave consequences, especially in spinal surgery and neurosurgery. But no matter who you are or where you're working, there are always mistakes, and you always have to. The main thing is, I think, learning from them, and always finding a way so you can tell yourself, okay, that's happened. How can I make sure that that doesn't happen again?
Yeah.
And I think you have to be honest with the patients and always, tell them exactly what's happened, and explain how you would stop that from happening in the future. And I think that's a standard we should all try and adhere to.
Absolutely. And do you have any kinds of personal tips or tricks that you use when something's not going as you would like it to during surgery, and you're trying to get yourself to focus and just keep going, because it's easy to get into a haze and get distracted?
There is. I think this is again where teamworking comes into it. And I think you have to use all the members of your team. Even if you're the senior person on the team, having a junior person there, there are some times when you just need to take a few moments out, just a step back and reevaluate things. When patients are under anesthesia, actually most of the time they're quite stable. If you need just a short break to even just rethink things, you can always reassess and reappraise. That's usually a safe thing to do. Anaesthetists have a lot of experience. Other people in your theatre team, if there aren't things you can happy with, you can always ask for other people's input. Ultimately, as a surgeon, they may not be able to help that much with surgical decision making, but I think you can always take the time out and have a think.
Fantastic, thank you. Right, got loads of questions coming in. Thanks, guys. So Nathan asked, do you ever have to operate on the spinal cord itself?
Yes, we do. So I mentioned what we call intradural tumours. Those are probably the most frequent reason for operating on the spinal cord itself. There are other times where you can have build-up of fluid within the spinal cord, known as a syrinx. Very rarely there are vascular malformations within the spinal cord tissue that sometimes need removal, or cavernomas, which is another form of benign tumor. So there are reasons to operate on the spinal cord itself. Many of these things I've talked about are actually very rare, and obviously operating on the spinal cord is at the more extreme end of risks. So again, we only do these things when it's really necessary. Yeah. So if people have really a progressive pathology, something that needs treatment. But yes, we do.
Cool.
I'll just say the other thing that often makes it as safe as possible, we use electrophysiological monitoring whilst patients are asleep. So they'll have special electrodes and pins in various muscles around their body, and we can actually stimulate the spinal cord and nerves within the operation to see how those responses are changing. So that can give us some idea of whether there's been any damage to important neural tissue. And so that helps make it safe.
Yeah. There are lots of tools and technology now coming out that can make neurosurgery and spinal surgery safer. But again, I think the key is when to use it, when is it wise to use it. Sometimes having too much information can be a hindrance as well, I think, so if that's safe to say.
Yeah, that's true.
Someone has said RSCHD. Can a European grad apply for this specific residency? If so, what steps? I think the only thing we can really comment on is about the United Kingdom training pathways, because that's what we know. Talking about Europe, we don't really know how things work in France, Germany. We've got a rough idea, but we wouldn't be able to really advise you. But with regards to becoming a complex spine surgeon in the United Kingdom, as a neurosurgeon, we can probably comment on that.
Yeah, so as I said earlier, there's different training programs within orthopedics and neurosurgery. So you can enter spinal surgery either of those routes, and both involve doing spine surgery during registrar training. So just to give a brief outline, after medical school you have your foundation years, followed by specialist training. In neurosurgery, that's an 8-year training program. And the later stages you can specialize more and more in spinal surgery. Orthopedics, I'm not sure if it's an 8-year program. It may be 2 separate programs at SHO and registrar, which are the 2 different training grades. And during the registrar years, which are the more senior years, again you start to specialize more then. And then there are specialty fellowships in complex spinal surgery, offered by orthopedic and neurosurgical departments, and at that point you can actually change over as well. So to some extent neurosurgeons can apply to orthopedic fellowships if they want to gain specific orthopedic type surgery skills which they may not have got during their training.
Thank you very much. That actually answers part of Gideon's second question. I think he's asking, have you done a PhD? Where are you currently in your training? Are you doing any fellowships? God, you're asking, Gideon, you're asking lots of questions in one go. Why don't we start with, have you done a PhD?
I haven't. I think a lot of this is personal preference. I don't think it's mandatory to do one, certainly in this country, and I think in most countries, to be honest. If you have an academic interest, I think it's completely reasonable to do it.
Yeah.
It just depends on your personal preferences.
Cool.
It is a long time out of training, and I think you've really got to have a keen interest and not just be doing it as a box ticking exercise.
Absolutely.
But I think it's a good thing to do if you're keen to do it.
Aaron Davies J. Hi, would you say doing an academic foundation program makes you a more competitive applicant when applying for specialist posts in this field? So another interesting question.
Yeah, it probably does to some extent, more on the basis that academia does count in terms of your shortlisting scores for neurosurgery. So if you've done an academic foundation job, you're probably likely to have more publications and presentations and things. But equally, even if you haven't done an academic foundation job, if you can do those things, which hopefully most people do to some extent, then I don't think it will hinder you not having done one. So I think you can argue it either ways. Additionally, obviously, doing an academic program means you're spending less time in clinicals, so that has some drawbacks as well.
Yeah.
I don't think it makes a huge amount of difference as long as you've been involved in neurosurgery and have done the right things prior to application. I think you can do well either ways.
You haven't done
I personally didn't.
Yeah. I haven't done one. I mean, we're N equals 2, but there aren't that many neurosurgeons and neurosurgery trainees in the country. So, and there are not that many who have done academic foundation programs.
Again, I think if you have a genuine interest in academia, definitely go for it. But if you don't do an academic program, I don't think that should put you off.
Right, Sharon Glenn again. What would be your advice for a new medical student starting a surgery rotation? It's quite a common question, actually.
During medical school, not okay.
Yeah.
Fine. Well, I think you have to always ask yourself, how can I get the most out of this rotation? I think seeing the patients and spending time with them, looking at people's individual journeys is very important. And when I was a medical student, I always found that's what really helped cases stick, and that's how you learn from them. I know in neurosurgery it's not stressed very heavily on the curriculum. So a lot of the places I've trained, medical students would sometimes just turn up for a day or an afternoon and come to theatre.
It's very common.
And that's fine, but it's a bit like being a tourist there. You don't know the patient, you don't really have an idea of what you're trying to achieve with the operation. And fine if you only have a day, that's all you can do. But I think things just don't stick that way.
Absolutely.
I think if you've seen the patient beforehand, you understand why the operation's being done, you're much more likely to remember something. And I think when you come to your exams or future life as a doctor, these things do stick, and you remember, oh yeah, there was that patient I saw, they had something wrong with them, and we took them for an operation and did this, and I think that's the way to learn.
Absolutely. There's a lot of etiquette involved with being in an operating theatre that you're not taught as a medical student. And I think you could probably spend about half an hour talking about that in and of itself. It's probably a video that we could do on Brainbook at some point. But again, like Mr. Tackler says, you know, if you do go into the operating theatre and you're noticed as a medical student and you're there and you get asked questions about the patient and you haven't met the patient before, then sometimes it can not look so good. And then sometimes surgeons may be a bit reticent to involve you more. So showing a bit of initiative, being quite keen. But then again, it depends on the day, it depends on the surgeon, it depends on the anaesthetist.
I think historically that's how a lot of surgeons train, so they kind of expect that.
Yeah.
Obviously, if you're only there for an afternoon or a day, it just might not be possible. But that depends on your medical school, I guess. And the other thing is to know your anatomy. I think anatomy is absolutely crucial to surgery, and surgeons love grilling medical students about anatomy. So
every surgeon ever. Basically.
Exactly. So brush up on whatever anatomy is relevant to that operation. And again, that will just help things stick in your head.
Perfect, thanks. Gideon asked, so this is part 5 of his question. We know Gideon, that's why, don't worry. If you had to summarise the top 3 things that you learned from your training, these are difficult questions today, guys. Difficult questions.
It's a job interview.
Yeah. Maybe why don't we start with one?
The top things from training. Again, there's I'm not sure how you answer that really. There's
we can come back to it.
There's a lot of different things in terms of the skills you've learned, in terms of good outcomes you've had with patients, exams passed. There's a lot of different things really. It's a very tough one to answer without really thinking through.
Absolutely. Maybe we'll come back to it.
Yeah.
So Sasha's also a Brainbooker. How did you decide, or why did you decide to subspecialise in spinal neurosurgery instead of the other ones? What interests you the most about this job?
Okay. I think we talked about this.
We did touch on it earlier.
So I think spinal surgery just it has a lot of challenges, both operatively in terms of procedures you do. And I think the outcomes as well. I think there's the opportunity to do a lot for your patients. I think you have a lot of patients with chronic pain, disability, and you can do a lot for them. So I think it's a very rewarding field to be in.
Absolutely. Arian, sorry if I haven't said it properly. Hi Mr. Tacker, surgical training is notoriously tough. What thoughts, motivations or ethos sustained you during your training when things got tough?
That's true. That's very deep questions again. It can be disheartening sometimes. We all have highs and lows. For whatever reason, long hours, stress. Sometimes you just have a terrible day and your patients may not be doing very well. All these things can affect you, and it can be hard to keep your motivation. I think having supportive family and friends, having colleagues you can talk to, and again, like I said before, having some hobbies, having something to take your mind off work when you're not at work is very important. But yeah, I think you need support of some kind, and again, it just depends on what setting you're in and who there is around. I think in the UK they try to have more and more structured forms of support in terms of you have an approved academic, clinical supervisors and training program directors and people you can go to for help if needed, depending on exactly what problems there are. But yeah, I think there's no doubt it is a stressful time. But
it is indeed. Shruti Sinha asks, I think you asked the question earlier that I was a bit puzzled about, but I wanted to ask whether a lower back problem like a disc bulge or prolapse can cause hindrance to a neurosurgeon's work. Interesting.
Yeah, that's true. It's
I think it's a fair question.
I think it is a fair question. I think it definitely can, especially in spinal neurosurgery, where a lot of the time we're wearing heavy lead gowns to protect us from radiation for operations we're putting in metal. Where if you have a back problem, then that can be an issue. But again, there's usually ways you can work around this. I know some surgeons who wear back support, you know, like sort of weightlifters almost during operations. So yeah, it can cause problems, but I think there are ways around it. And actually, by the time you're a consultant, you don't always have to be scrubbed for very long periods of time. You're there more in a supervisory capacity, and you don't have to necessarily be wearing a heavy lead jacket for hours on end. So it's probably a bit easier to manage than as a trainee. I think when you're training, it probably would be more of an issue. But again, I'm sure there are ways around it.
Absolutely. Start doing that Pilates and yoga and strengthening those core muscles. That's really going to help. Actually, believe it or not, you know, when you're working long hours all the time, a lot of us do let ourselves go a bit, and then and that's when all these things start to creep up on you, and you start getting neck aches and shoulder aches and back aches and things like that. So self-maintenance and exercise and things like that during surgical training is probably quite important. It's just finding the time to do it. That's it. Nathan, what advice would you give to someone who wants to go into neurosurgery? It's quite a broad question. Do you reckon you could probably try and narrow it down a bit and then ask it in the comments section, and then we'll try and narrow it down a bit? That's a pretty broad question to ask. Rachel Heaton, I'm a newly qualified physician associate. I have a background of biomedical science focusing on spinal and neural tumours. My question would be, do you feel there's a role for physician associates within the neuro team in the future?
Or even in the present.
In the present.
I mean, we have physician
associates
in our department here at the Royal London.
How many have we got? We've got 1, 2, 3. We've got 3 currently.
So yes, to answer your question, yes, definitely. I think they do a very valuable role, and actually they provide some important continuity as well. I think a lot of the SHOs are on call rotas and things, doing nights, and they're off post night, so sometimes that continuity isn't there. So I think they are very helpful in helping some of that continuity, and they do very good work on the whole.
Absolutely.
So we look forward to continuing working with them.
Fantastic. Gideon, what are the most common surgeries that you perform?
So the most common are probably the things like microdiscectomies, laminectomies, anterior cervical, disc operations. These are so largely decompression operations and simple fusions. But particularly in a hospital like this, we're very busy with trauma, so we have a lot of fixations as well for trauma. Many of these can be done percutaneously, so there's a lot of tumor work as well. And on the orthopedic side, they do a lot of scoliosis correction. So there's a very broad spectrum of things, really. So overall, I think decompressions are the most common operations in any spinal surgeon's practice. But there's a good mixture of all the rest.
Brilliant. Alex Canning asks, hi guys, I was wondering how you think foundation and specialty training posts compare around the UK for surgery. Some old...
for surgery in general, are we talking, or...
Let's talk about neurosurgery, because that's what we know.
There aren't many foundation posts in neurosurgery. I know some places do have F1s and F2s in neurosurgery, but I think that's not standard. I think most people applying into neurosurgery specialist training will have spent some time in their departments as medical students and really kept in touch with their departments to develop that interest. And they may have done elective and things abroad before applying to neurosurgical training. Within neurosurgical training, there's always going to be some level of variation, but everywhere has to meet the final standard. And when you're having your final sort of assessments, there's a certain standard everyone has to reach in terms of clinical competencies, academic output, all of these things. So really, I don't think it matters where you train. Everyone gets there at the end.
I think the only major difference that probably matters is if you're in London, then you do rotate around a lot of different hospitals. So we're in North Thames. Mr. Taco was a South Thames trainee originally, is that right?
Yep.
So South Thames goes all the way down to Brighton on the south coast, has King's College Hospital, St George's Hospital, it was Hurst.
That's Brighton now.
It was Brighton now. Yeah. North Thames includes the National Hospital for Neurology and Neurosurgery, Great Ormond Street, the Royal London where we're based, Romford, Charing Cross Hospital. So actually throughout your 8 years you can be posted all over London and you can get quite a wealth of experience. Not with regards to the kinds of operations you do, but
so everywhere for neurosurgery is essentially a tertiary centre, so they deal with most parts of neurosurgery. So you'll get the experience everywhere. I guess there's a balance between, if in regions where you just stay in one unit, you probably make faster operative progress. Just because you know everyone, you start to get given that responsibility a bit sooner. In places like London, where you rotate around various different hospitals, there's always a bit of lag time. Every time you go to a new hospital, you have to build that trust again.
Absolutely.
But then in the long run, I guess you're exposed to a lot more variety in terms of how different people do certain things. So that has its benefits as well. So I think there's benefits to both ways, but I think everywhere in the country you'll get good training.
That's it. Right. So Asif Ali asks, so we've kind of answered this question before, does spine surgery require both neurosurgeons as well as orthopedics? When this live stream finishes, it will be on the channel and you can watch it from the beginning. We've answered that to an extent. But thanks a lot for joining us. Hi Tori, good to hear from you. Yes, Basker loves Kings. We love Queen Square. This may sound weird. Is there any subspecialty in neurosurgery that is related to psychiatry? Asks Shruti.
It kind of went out of fashion a little bit. There was some psychosurgery going on probably in the 1950s with some questionable practices and outcomes. So I think really it went out of favour. And I think psychiatrists have been quite reluctant to refer their patients for neurosurgery ever since. With deep brain stimulation, there's an increasing role. Things like the new indications are being found for treatment, like depression, OCD. So there definitely is a role for surgery. So places offering functional neurosurgery, there will be an increasing role, I think, in years to come. But it's not totally routine as yet.
And at some point, maybe we can get someone who does deep brain stimulation to come on the channel and do a live Q&A. Maybe we can go into a bit more of that. So, Sharon Glenn would love to hear about any specific case that you've encountered that was particularly interesting or challenging at that time. Difficult question to answer with regards to case anonymity and so on and so forth, but we'll put the question out there. Is there any particularly interesting case that was challenging or interesting at the time?
Again, that's a very difficult question. We have so many. There are so many interesting cases. I think in the spine, I think some of our tumour cases are particularly challenging. We've had some interesting cases with intramedullary tumours this year at the Royal London, which I've been a part of, and they carry a very special sort of set of skills that are required to operate on these tumours. So I think those are particularly interesting. But really, I think you can get find a lot of different things are rewarding. So
right. Gideon, does robotics play a massive role in your day-to-day surgery? If not, do you think that there's a future for it?
It doesn't play a massive role at the moment, but we do actually have a robot at the Royal London, and due to start using it in the next month or so. The trial phase is already done, so we're ready to go with it. It's obviously not the standard of care in most places, but in years to come, as the technology improves and becomes affordable, I think it will be more and more widespread. I think at the moment the literature probably suggests the sort of accuracy of putting in screws and things freehand is not as accurate as if you use a robot.
Sounds fair.
So I think at the moment you definitely need to be able to do things, both ways. But as the technology improves, I think robotics will become routine.
Yeah.
I think with the additional guidance it gives you, if you're a patient, would you want that extra guidance for you if you're being operated on? I think the answer is yes.
Yeah, I think so.
Yeah.
And once we're using that robot here a bit more, and all the surgeons are fluent using it, we'll try and get a camera in there and show you guys how it works. We've seen it. It looks very, very cool indeed.
And just a quick point on that, I think people think robotic surgery at the moment will be the robot actually doing the entire operation. That's not what we're talking about. For spine, really, the robot will have a robotic arm which will actually guide you as to where to insert your screw, trajectories, these sorts of things. So it's not actually doing the operation. I think we're a long way, not a long way, but we're a way off the robot's actually doing the full operations at the moment.
Fantastic. We've got loads of questions coming in here. Let me know if you need to take a break or if it's starting to run dry. You can go for a bit longer. Arian asks, how would you recommend medical students approach you as a consultant or complex spine fellow to get involved in meaningful surgical research? Are there study designs that you would suggest are not feasible at this level?
So again, I guess it depends on what your interests are. I think if you're talking actually about setting up a new study, then that can be a lot of work depending on what exactly you have in mind. If you already have some research questions in mind, that's always a good thing. But if not, if you just want to get involved, I think it's always a good idea just to approach consultants that are academically active in your department, and people are always happy to have people involved in things.
Absolutely.
So definitely approach people in your department. And if you have some ideas or any particular areas you're interested in, either from preclinical studies or things you've read, then mention them. Otherwise, even just making yourself available and saying, look, I'm here to do things, write up cases, start with simple things, that's always good.
Yeah. And sometimes, when I was a medical student, usually certain consultants or registrars will have a reputation. They'll either be highly academic or have a good publication output, or they'll just be approachable people.
Yeah.
And the people that are not so approachable will have that reputation, so you'll know maybe not to waste your time so much. Again, if you're friends with the SHOs, house officers, registrars, they can give you good tips on who people are to approach. But one thing is that the consultants get a lot of emails. So if they don't reply to you, I would certainly give it some time and do email them multiple times, because honestly, sometimes they get thousands of emails in a week and it's very difficult to keep up, so yours will get missed. Sometimes the best way is to go through a secretary if you've identified someone, and then try and make an appointment to see them. And then if that fails, then you've done your best, right?
You can always just turn up.
Just turn up at their operating list. I've done that.
Yeah, exactly. There's different departments set up differently, but here we have a morning meeting sort of every day. So there are different ways to get involved. But I think most consultants will respond to an email and be happy to have you involved.
Ali Al-Jabari, we'll talk about brain transplants another time. That's a can of worms, and a lot of neurosurgeons have got quite strong views on this. So maybe we'll come back to that one. Rachel Heaton, for my fellow PAs in other surgical specialties, PAs develop to first assist. Is this something that you'll foresee happening, or is it already in place?
So first assist. Does that
like what I do for you?
Oh, okay, fine. So in terms of the theatre, I haven't seen that in neurosurgery. I'm sure there is a role for it.
They do.
Okay, fine. They do here.
Sometimes.
Okay, fair enough. Yeah, I mean, I don't see any problems with that. I think they could assist in operations. Yeah, they do come down definitely.
Yeah, absolutely.
Yeah.
I think PAs are in a very unique situation at the moment where, as long as they have someone senior supervising them, the world is their oyster. So, and most neurosurgical operations will be senior registrar or consultant led. So that supervision's there.
And yeah, I think the PAs, if you're mainly on the wards, it's really nice to see what actually happens in theatre, because ultimately everything you're doing is to support them pre-operatively or post-operatively. If you have no idea what's actually happening in the operations, it can be hard to sort of put it all together. Yeah. Sometimes it just makes a bit more sense if you actually go and see what's going on there.
Exactly.
And it helps motivate you as well. So I think that's a really good thing to do.
Absolutely. Asif Ali, is there anything like 3D printed spine? The answer is yes, but not to implant in patients at the moment. Right?
Not yet, but they are working on it. I know some companies have started offering implants for, say, putting in screws. So I know some companies do a thing called C1, C2 fixation. So you can, if you have a fracture that you're planning to fix, you can send them the scans, and they'll make a drill guide for you. So when you open up, you do your muscle strip and sort of clear the bones, and then you can just put the drill guide onto the area, and there's pre-made holes in which you can just stick the screws down. So I think 3D printing is being used already, and may have more of a role in the future.
We've certainly used them here for patient consent and patient information giving, and we've used them at the King's Conference last year to teach medical students and undergraduates. People loved it. I mean, it's something that you can hold and feel, and rather than just looking at a scan. Arian, wow, there's loads of questions coming in. Sorry about the question overload. Seeing as though juniors start out assisting, what makes the perfect surgical assistant? Conversely, what do you loathe to see in your surgical assistants? Bearing in mind, I assist him, right?
I think it's always important to have a coffee ready for the boss. No, I'm joking. Sorry, that was a joke.
I do that.
I think, being a good assistant, you do have to know the operation and be able to concentrate for long periods of time. It might not always be the most interesting thing to just be assisting. But certainly when I'm teaching juniors, or even if I'm leading on an operation, if there are parts of the operation they can do, I will always try and get them to do those bits, so everyone feels like they're getting something out of being there. But actually, if you can tell how well somebody knows the operation by how well they can assist you, so that if somebody knows what they're doing, they will know what step you're doing next. So actually, assisting is an important thing in terms of knowing how to do an operation. But ultimately, obviously, you have to do the operation. But
and what do you loathe to see in
your
surgical assistants? What do I do to annoy you, Mr. Tacker?
Nothing at all. I guess if they look like they're completely disinterested in what's going on, I guess that's probably not a positive thing to see. But that's usually not the case.
Falling asleep on the microscope.
I think as long as they're awake and and doing their best to help you, I think that's the important thing. Exactly. Because a lot of the time you do need them to do a good job and to be focused. Assistant's job is very important, especially in neurosurgery. You might have them retracting on a bit of brain or something like that. So even being the assistant carries a lot of responsibility.
Absolutely.
So they need to be focused. So I think they need to be interested.
Yeah, doing an operation with a bad assistant can be painful.
Yeah.
Aurelius, what do you think about chiropraxy? Do you ever suggest a patient go to a chiropractor over surgery? Oof.
That's a tough. I'm sure we're going to get some angry replies from chiropractors depending on what I say here. So personally speaking, if I don't often recommend people go to chiropractors, but I have had patients who've seen chiropractors for conditions where we're trying to manage things conservatively, and they said the chiropractor really helps. So if people say I'm thinking of seeing a chiropractor, a lot of the time I'll say, well, actually, fair enough. If it helps you, great. If it doesn't, then we can rethink.
Yeah.
I guess the only time I would recommend people didn't is sometimes if they have a disorder in which there's tight compression on their cervical spine, on their spinal cord, something like that, and I'm worried about a manipulation or some sort of maneuver that might actually injure the spinal cord. But I guess those are a minority of cases, and I'd hope the chiropractors would know better than to do that in those cases.
Yeah.
But apart from that, I think it's generally okay.
Yeah. And a lot of good chiropractors already request MRIs of patients
Exactly,
with pathology
yeah.
before they touch them. So,
Yeah.
It's all about choosing the right person, isn't it? Arian, you're going, it's good. You've alluded to the importance of hobbies. What hobbies do you engage with? He talked about that at the beginning. You're going to have to re-watch. Do you think it's important they complement your work, e.g. doing art for dexterity's sake? Coming from a champion pianist.
I wouldn't say champion,
Yeah,
but
he's modest.
no, I don't think they need to complement it. I mean, I think great if they do, but I think when I was talking about hobbies, I was saying it's more to get your mind off work rather than think, how can I make my work better? I mean, if you do have hobbies that are good for manual dexterity, that's fine. But I know some very good surgeons who, don't do art or play an instrument, and there's also the converse, which we won't go into.
Yeah, exactly.
So yeah, I think if you do, great. But as long as you do something that can take your mind off work and keep you sane.
Perfect. So we've got probably 10 minutes left.
Yeah.
Does that sound fair?
Yeah.
Yeah. So, Tori, do you have lots of patients with psychiatric comorbidities? Do you liaise with the psych team for this reason?
Yes, we do. I wouldn't say a lot of patients, but it's. Psychiatric patients suffer from medical problems like, particularly in spine. So we definitely do see patients with psychiatric issues. There can be issues around consent and capacity, so that can have challenges. So in complex cases, we'll often involve the psychiatrist for this, and their input's always valued.
Yeah. Of course, a lot of the time, sometimes our patients can get psychiatric problems after a particularly complex operation as well. So
yeah, but, more on the brain side.
More on the brain side,
Right.
Yeah, sorry. I mean, because even though Mr. Taka is a complex spine surgeon, when you're on call or if you're supervising junior colleagues, there will be times where he's doing a lot of cranial or brain surgery. So you don't stop doing that as a neurosurgeon, I don't think. So it's always important to have these things in the back of your mind. Do you use any navigation systems for spine interventions?
So as I said earlier, we are going to start using a robot which involves navigation with it. So this will involve the patient's preoperative scans being loaded into the robotic system. Robotic spinal surgery does involve using navigation as a part of it to help you do fixations essentially.
Thank you. Tori, the question about someone who didn't know about spina bifida until their 50s, when their vertebrae started crumbling, would there be any sort of surgery that could be done to decrease their pain or posture? Difficult to ask in this situation because you don't want to give an opinion on something that you've not seen scans for, don't know the patient, stuff like that. So we'll probably try not to go into that if that's okay. Can you describe the method? So Simon West, can you describe the method you'd go through to prepare for surgery? We've talked about challenges and fallback, but I suppose how do you mentally prepare yourself for surgery?
I think everyone has a different routine, either on the morning of surgery or within a few days before, when you know what your operating this is going to consist of. You always have time. You always need to take the time to go through scans, go through patients' histories, go through their letters, make sure you've got to try and foresee problems before they happen to avoid issues on the day of surgery essentially. So You always need to know what's going on with your patients, checking that they've been appropriately worked up, making sure you have the right scans, and taking time out to go through them really. So again, everyone's got a different routine for how they do it.
Yeah.
I think you just have to work that out for yourself to some extent on how you do that.
Yeah, I think for a lot of neurosurgeons it's going to be preparation,
Yeah.
and making sure that you've planned for all eventualities before you even put knife to skin. I think that's what most neurosurgeons will say.
Yeah.
It's a quite core concept of neurosurgery on the whole, because if you get the beginning wrong a lot of the time, it can make the rest of the operation really difficult.
There is that. You have to have meticulous planning, and you always have to have a plan A, a plan B, and a plan C. So you always need to have a backup for worst case scenario and how you deal with that.
Yeah. Tori asks, what's the grossest thing you've seen in surgery?
Probably can't answer that on live YouTube. But it depends on what you count as gross, and we have to deal with a lot of infections of the brain and spine. I think those can be quite gory at times. When you see a high volume of pus come out from inside someone's head. Right,
and the last question we're going to answer, unless there's another one after this, I think this one will be short. Can a person with Tourette syndrome be a surgeon? Is a steady hand necessary? Isn't it? These are some really interesting questions coming out today.
Tourette's. I guess again, Tourette's is quite a wide spectrum of disorders. I think if you had very bad motor tics, I think it would be difficult. Even the verbal ones, I think, could be challenging if in any medical field really that you have to interact with patients. So there would be challenges,
but you can work around it. As long as it's, I suppose, with motor tic, like you said, motor tics in neurosurgery probably a bit difficult to get around. But verbal Tourette's, I mean, so as long as the patients don't mind, I suppose.
It would be. It would have an interesting challenge, but it's possible.
Perfect. I think that is it for questions. It's been nearly an hour, so I just want to thank Mr. Taco for coming along and answering all of your questions. Thank you guys for coming and for asking questions. We're going to try and do these Q&As twice a month. The next one's going to be in 2 weeks, and it's going to be Miss Gronia McKenna, and she's going to be talking about neuro-oncology surgery and being a woman in neurosurgery. Shashank has just put through a question, but we're going to talk about IMGs another time. So if you want to support us, subscribe to us on YouTube, and you can take a look at our Patreon page as well if you want to consistently support us. We are a charity. This is all pretty much self-funded, so any support would be appreciated. Thank you very much, guys. Thank you, Mr. Taco.
Thank you for having me. Cheers.
Bye, guys.
Bye.